Over to you.
Thank you very much, sir. Good evening and a very warm welcome to all of you. It's a new day at the RSACP Conclave 25, and with it, we open another chapter, one that continues our collective journey of leading, learning, and reimagining the future of anesthesia. So each of the presentations that we have today, they carry the imprint of that live rigor shaped by observation, inquiry, and the commitment to improve care. And it gives us great pride that this session is being chaired by two senior women anesthesiologists, clinicians, and mentors whose work has shaped the path of many of us who walk today. This conclave is more than a platform. It is a signal that the next generation of anesthesiologists is not waiting to be invited to the table. They are here with skill, with voice, and with vision. From OT table to paper tables, today the future speaks, and we are here to witness it, support it, and celebrate it. So, fasten your seatbelts once again. Let us begin this evening session with curiosity, attention, and deep respect for the science and spirit that brings us together. So I now invite our President, RSACP National, Dr. Naveen Malhotra, sir, to share a few words, sir.
Good evening, all. And it's a pleasure to welcome you all to the second session of RSAP Youth Conclave 2025. A fortnight ago, we had presentations on research by the postgraduates and senior residents. And this week, we are having presentations from the consultants less than 40 years of age. The results of both will be announced together in a couple of days. And then we will have weekly sessions on Talk It Out, infographics, and ultimately leading to a final round wherein it will have a bigger prize and the grand finale winner becomes the RSAP Youth Orator of the Year and will deliver an orational lecture at the annual national conference of RSAP 2026 at Indore. So I'm thankful to Dr. Tanveer and Dr. Neha and Dr. Nitin and Dr. Neha Mishra for spearheading this youth conclave, and always thankful to Dr. Vishal for supporting this endeavor. I'm really thankful to both the judges, the past president of RSAP National, Madam Indrani Himmat Kumar, and the president-elect. So I am a sandwich between both of them, but they both are supporting me and guiding me, and they are always available for any work pertaining to the association. So thank you both the judges. I know you will be having a tough job because we have got very seasoned faculty members who will be discussing about their research with both of you. And best wishes to all the participants. We have got a mix of flavor, both ladies and gentlemen from all over the country. Good luck to all of you. Thank you very much.
Thank you, sir, for your encouraging words. So I would now invite our Honorary Secretary, RSACP National, Dr. Vishal Singla, sir, for his words, for his encouraging words, sir.
Good evening, everyone. My regards to President Dr. Naveen Malhotra, sir, President-elect and Chairperson of the today, Madam Manju Garewal, past President, Research Society of Anesthesiology, Dr. Indrani Hemant Kumar, Madam, and all the delegates present. Thank you to each and every one of you for being here with us in this Youth Conclave Part 2. Research Society of Anesthesiology has always been a pioneer in promoting academics, and continuing in the same spirit, we are continuing with this Youth Conclave for the candidates below 40 years of age. A proud moment for Research Society of Anesthesiology to hold this Youth Conclave, to give a chance to showcase the work for youth. Continuing in the same spirit, we have brought in this conclave to nurture the power of youth and the chance for the youth to showcase their work. I would like to thank our national coordinators, Dr. Neha Sinha, Dr. Tanveer Singh, Dr. Neha Mishra, for their for the work they have done to make this project a reality. Once again, I would like to thank everyone and all the best to the seasoned candidates. Thank you very much.
Thank you very much, sir. So, without any delay, I would now like to invite Dr. Naveen, sir, who is going to share a big news with us, which is regarding the 8th June session.
Uh, Dr. Neha, I think we will declare the winners together.
Right.
And but still, if you want, since you have asked me, so I will definitely share the winners with you all. And the winner gets goes to the first of all, the first winner goes to the second session, the second round, and where they will be competing for a cash prize of 25,000 plus a chance to become a national orator. And the results sent by judges are: the first prize goes to Dr. Poonam Godwal from AIMS, New Delhi. Second, to Dr. Jain Roy, SGPJ, Lucknow. And third, to Dr. Shrishti, AIMS, Guwahati. The second and third prize winners gets a memento, a medal, and a certificate. Dr. Poonam Godwal gets cash prize of 10,000, and she goes to the next round, where she will be competing with the winners of the all the subsequent rounds. And I repeat, the winner will get 25,000 rupees and chance to deliver the annual oration, the Yuva annual oration in Indore on 10th and 11th April 2026. Thank you very much.
Thank you very much, sir, for that very wonderful, encouraging news. So now I would like to invite our chairpersons for the day.
But before I uh, say that these three are winners, all the participants in the last session, for us, all are winners because they were shortlisted from the multiple entries. So rest, they should not feel a bit disappointed. Better luck next time. But for us, you all are winners and you will get a certificate of appreciation from the association. Over to you, Dr. Neha.
Thank you so much, sir. So, so that was for the previous session that we had on 8th of June. Moving forward, without wasting any much time, I would now like to invite our chairpersons for the day. Like I said, two very amazing women anesthesiologists who have motivated all of us. So, first of all, I would like to welcome Dr. Anju Grewal, ma'am. Ma'am is the president-elect of the RSACP National. She is the professor and head at the Department of Anesthesiology, AIMS, Batinda. Among the few achievements, many that she already has, ma'am is the editor-in-chief in Anesthesia Tutorial of the Week, flagship publication of the World Federation of Societies of Anesthesiologists. She is the national president at the Association of Obstetric Anesthesiologists, India. She has been awarded the honorary fellowship in Obstetric Anesthesia and Airway Management Foundation, an associate editor, International Journal of Regional Anesthesia, an editorial board member of Indian Journal of Anesthesia, JOACP, JOACC, and JIMA. Ma'am's areas of interest are obstetric anesthesia, CPR, airway, acute pain management, trauma anesthesia and acute care, regional anesthesia, scientific communication, safety issues, and in perioperative care. We welcome you, ma'am.
So much. Thank you, Neha, for such a warm welcome.
Next in line, we have none other than Dr. Indrani Hemant Kumar, ma'am. Ma'am is the professor and head at the Department of Anesthesia, Pain and Critical Care at Symbiosis Medical College for Women at Pune. She is the past president of the RSACP National, president of the state chapter of Indian Association of Pediatric Anesthesiologists, current governing council member of the Indian College of Anesthesiologists, governing council member of the Society of Oncoanesthesia and Critical Care, governing council member of the Association of Medical Consultants at Mumbai, governing council member of the Maharashtra state chapter by the ISA, and she held 3 terms. Past president of the ISA Mumbai, member specialist board at the NBE. She has a fellowship awarded by the Indian College of Anesthesiologists, FICA and SOPCC. Ma'am is the recipient of Har Gobind Fellowship, where she had went to train in cardiac anesthesiology at Lehigh Valley Hospital, Pennsylvania. More than 12 chapter in books and Natya Kalaimani Award, Bharat Jyoti Award recipient. Sorry, ma'am, if I pronounce that incorrectly. We welcome you all to RSACP Youth Conclave.
Thank you so much, Neha.
Thank you so much, ma'am. Most welcome. So now I would like to invite my state coordinator, very able Dr. Neha Mishra, ma'am, from Uttar Pradesh, to take over the stage and invite our speakers for for continuing this session. Over to you, Dr. Neha.
Thank you so much, ma'am. I would like to invite our first speaker, Dr. Pooja Bihani, ma'am. She is Associate Professor, Department of Anesthesiology, AIMS, Bhubaneswar. She'll be talking on striving for excellence in ventilator bundle compliance through continuous quality improvement initiative in an intensive care unit of a tertiary care hospital. Please welcome, ma'am.
Thank you so much, Dr. Neha. Thank you so much, team RSCP, and a very good evening to everyone. Special thanks to Naveen sir as well as Dr. Vishal for taking this initiative and presenting our research work.
Pooja, 1 minute. I would like to interrupt 1 minute.
Yes, ma'am.
Neha, is there a time frame for this?
Yes, ma'am. Ma'am, each speaker will be getting 8 minutes. I'm going to give a audio cue at around 7 minutes and 2 minutes for the discussion, ma'am.
Okay, fine.
So my topic is basically on the ventilator bundle compliance improvement. It was basically a quality improvement initiative, which was taken in the intensive care unit of tertiary care hospital in Western India. And as we all know that the ventilator associated pneumonia is a big and problem worldwide, especially in the developing countries in India, like India. And it is a preventable nosocomial infection, basically. The high incidence rate is encountered worldwide, but the incidence rate is still high in the developing countries like India, where the reported incidence varies from 10 to 14.7 per 1,000 ventilator days. And the Institution of the Healthcare Improvement as well as the Nosocomial Infection Society, they have reported that the simple ventilatory bundle implementation, not only the individual component of the ventilatory bundle, but the complete entire bundle implementation has shown to decrease the rate of VAP. It is just a preventive strategy, and which included like, is my screen visible?
Yes, your screen is visible.
Not visible from my end, basically.
You can present in this form itself.
Okay.
Yeah.
So it's included oral care with chlorhexidine, stress ulcer prophylaxis, daily sedation assessment, DVT prophylaxis, head of the bed and elevation. This simple complete bundle implementation has shown to decrease the nosocomial infection, that is VAP, by dramatic incidence rate reduction. But despite knowing that this is very important preventive strategy, the knowledge as well as the implementation of ventilator bundle remains very low, especially in the developing countries like India. So going with that, we also wanted to conduct one survey in Indian population as well as in our ICU setup, where the knowledge as well as the compliance with the ventilator bundle was shown. And it was, we found a surprisingly high incidence of less compliance with the ventilator bundle. We found that the observed compliance was just 40%, despite the knowledge of ventilator bundles remains high in the residents as well as the nurses, like 7 as well as 6. And the self-reported adherence to the ventilator bundle was 75 to 95%, but the reported compliance was very low, that is 40%. The least compliant component was daily sedation interruption as well as the DVT prophylaxis. So on this basis, we plan to conduct a continuous quality improvement project to increase the compliance with the ventilator bundle protocol at our tertiary care institute and to evaluate its impact on the VAP rate. The primary objective and the smart objective of this quality improvement initiative was to increase the compliance by more than 90% over a 6 months time period in all the patients who are on the ventilator support. We also wanted to see the impact of this project on the incidence of VAP, the duration of ventilator days, and the length of ICU stay. So our study was basically a PDSA cycle model of QI project. And we conducted this study in a closed ICU where we used to admit mixed range of medical and surgical population. It was a 15-bed ICU where the staffing ratio is 1 nurse every 1.5 patients, and resident doctor is posted for 1 doctor for every 4 patients. We included all the adult patients who are on the mechanical ventilator support, while the patients who are already intubated at the time of ICU admission, suspected C-spine injury, and onset of pneumonia before the ICU admission, and Apache score more than 35 were excluded from this study. Because it was a pre and post implementation study, so consent of the patients was waived off. In the initial 6 months period, we conducted wave baseline survey, followed by we conducted several PDSA cycles, and after conduct of the PDSA cycle for every 1 month, we observed the compliance with the ventilatory bundle. So at the end of when we ensured the compliance by more than 90%, we again calculated the incidence for next 6 months. So during the pre-baseline assessment, needs assessment, and the root cause analysis, certain non-modifiable factors like from the patients related factor were identified, and certain modifiable factors from the were identified like unavailability of the equipment such as oral kit, adherence, poor knowledge with the VAP bundle in the resident doctor as well as the nurses, lack of motivation in the healthcare providers regarding ventilator bundle compliance, and lack of accountability and supervision. So we targeted certain interventions to improve the nursing care, resident doctor care, as well as faculty in charge care to increase the compliance by more than 90%, ultimately to decrease the incidence of VAP. And we targeted every component of the ventilatory bundle, and importantly, the checklist implementation and improved accountability was sought for every aspect of ventilatory bundle. So in the initial first PDSA cycle, what we found that maybe knowledge is poor. So what we did, we conducted multidisciplinary boot camp involving of the resident doctor as well as the staff nurses, where we conducted didactics regarding the ventilatory bundle and every component, its importance, and certain video sessions. After that, collaborative weekly sessions were conducted in which the report or the every week report was being presented by the nursing lead as well as the senior resident doctor of the ICU. And we also pasted that weekly audit report in the ICU signboard for more accountability as well as transparency. But after the end of 1 month, we found that certain factors like lack of accountability and lack of supervision were the factors which were which were leading to decreased ventilator bundle compliance. So in the next PDSA cycle, we targeted these 2 factors, and we implied certain visual cues in our ICU, including of this ventilator bundle compliance placard, and which included all the component of the ventilatory bundle, and it has to be implemented in every patient who is on the ventilator support. Secondly, we incorporated one checklist in the ICU daily chart, and that checklist has to be, every component of the ventilator bundle was pasted in the ICU checklist, and that has to be signed by the duty nurse as well as the duty resident doctor, and countersigned by the faculty in charge of that particular month. Still in the next 1 month, we found that though they have good knowledge of every component of the ventilator bundle, but how to implement that, they don't know the proper protocol of implementation of VAP bundle. So in the next cycle, we conducted micro scenario, including hand hygiene, oral care protocol on the bedside of the patients. For proper head end elevation, we put 2 marks at the bed end side of the patients, in which when the head end of the elevated bed is elevated, only green mark is to be visible and the red mark should not be visible. And to increase the compliance with all the components of the ventilatory bundle, we conducted few high fidelity simulation scenario, including of all the healthcare workers of ICU. So by the end of 3 PDSA cycle, we ensured the ventilator bundle compliance raised from 90 to 92%, more than 90% we ensured. So over the next 6 months, we ensured the ventilator bundle compliance remained 90%, more than 90% basically, and calculated the incidence of VAP rate. So in the pre-intervention period, Total 97 patients were eligible for enrollment in our study, and in the post-intervention period, 104 participants were eligible. 5 were excluded and 6 were excluded in the post-intervention period due to various reasons. So total 92 patients in the pre-intervention period and 98 patients in the post-intervention period were analyzed in our study. Baseline demographic profile as well as severity score like Apache 2 at the time of admission and the at 48 hours after intubation as well as SOFA score were comparable in both the pre-intervention as well as post-intervention group. So the results were actually very supporting, that we found the rate of ventilator-associated pneumonia decreased to 26.6 per 1,000 ventilated days in the post-intervention period. That was earlier 62.4 per 1,000 ventilated days before implementation of the ventilator bundle compliance, ventilator bundle. And we found that after implementation, there was 2.3 times decrease in the rate of the VAP, as well as severe microorganism culture was also decreased in the post-intervention period.
Ma'am, you have 1 more minute left.
Okay. So the major impact of our project was, one important is the involvement of multidisciplinary team, not involving just doctors, but also staff as well as other healthcare workers to combat VAP through ventilator bundle compliance. And we have to bridge the gap between knowledge as well as practice through simulation-based training. We have to incorporate certain checklists, and that has to be incorporated in daily ICU chart for proper documentation and accountability by all the nurses as well as doctors. And visual cues like bed angle markers as well as placard are very nice initiative that can provide some visual impression what is to be done. And standardized protocol implementation definitely will reduce the incidence of preventable nosocomial infection. The key strength is it's our single center study. So the bias associated with different population was avoided in the study. And the VAP was identified by the standardized criteria as per the CDC. Next, after completing this study, we wanted to increase the stakeholder engagement to achieve ventilator bundle compliance at other ICUs of our institute. And we wanted to increase the compliance of ventilator bundle and sustain this compliance, finally to achieve VAP rate 0 at our ICU. This was our future goal in the coming months. So these are my references. Thank you.
Thank you so much, ma'am. Now I request Dr. Anju ma'am, our chairperson, to please go ahead with the discussion.
Yeah, thank you so much, Dr. Pooja. An excellent presentation, I would say. Wanted to know that what were your exclusion criteria,
Yes. From the participants' point of view, that exclusion is just only the voluntary disagreement. From the patient's point of view, our exclusion were if the patient are already intubated at the time of ICU admission, who was already pneumonia at the time of ICU admission, and high Apache score more than 35 at the time of ICU admission. And also if the patient are on the vasopressor support because head and elevation might be interfered, and patients like suspected C-spine injury were also excluded from our study.
Okay. So other question is, how did you address human behaviors, attitudes into your simulation or your other kind of PDSA cycles?
Yes, this was an important factor we encountered during the implementation of second PDSA cycle, because they have proper knowledge as well as the compliance with the ventilator bundle. Still, they found how to implement that thing. And accountability was ensured during the second PDSA cycle, but they don't know how to implement properly, like the headed elevation as well as the hand hygiene protocol. So we conducted few of the micro scenario and one high fidelity scenario for involving 4 to 5 participants, multidisciplinary team involving resident doctor as well as the healthcare workers, like one of the nursing staff as well as other healthcare, allied healthcare workers. Then after that, we conducted debriefing, and during debriefing, we addressed these are the issues which are being encountered during real patient care, and that has to be addressed during real patient care. So we found that these high fidelity simulation scenario, we conducted around 10 simulation scenario, including of all our participants, and that was actually useful.
Thank you so much. Over to Dr. Hindrani, ma'am.
Pooja, that was good. Actually, when I looked into the your heading, I thought ventilator bundle. I thought you were going to talk about tidal volume and uh, respiratory rate and PEEP and all that. Actually, it is ventilator care bundle, isn't it?
Yes,
Ventilator
ma'am.
care bundle.
Yes, ma'am.
Okay. So, what I would have expected out of you in this is what exactly, in terms of the nitty-gritties of those five bundles, means how often would you do oral hygiene care? Is it every day or every 12 hours or every 6 hours? And for, aspiration prophylaxis, what exactly you did? Were the patients ventilated patients or non-ventilated patient or non-invasive ventilation? So how did you manage those secretions, and what sedation protocol was used? And, something related to that, where all of them given DVT prophylaxis. Was it a mechanical prophylaxis or was it a pharmacological prophylaxis? All these nitty-gritties probably should have been incorporated in your thing, because that is part of your methodology, isn't it?
Yes, yes, ma'am. Yes, ma'am.
Also, another important thing which I wanted was, you were talking about the PDSA. So, you went from 1 to 2 to 3, isn't it? Initially WhatsApp, and then you had the posters, and then you went into simulation, isn't that? Am I
Yes,
right?
ma'am. Yes, ma'am. Yes, ma'am.
What I wanted to know was, did you analyze which of the PD essay had the maximum impact?
Maximum impact was with the 3. After the baseline incidence was 40%, after the first PDSA cycle, it increased to 47%. And after the second PDSA cycle, the VAP incidence was 75%.
And what was the criteria which you took into consideration when you progressed from 1 to 2 to 3?
So it was 1 month cycle, madam. 1 month
So
cycle.
you didn't have any criteria, because if the criteria was met in number 2, you wouldn't have gone to 3, right? So
Our criteria was to improve the ventilator bundle compliance to more than 90%.
exactly. So if you achieved your 90%, you wouldn't have gone to number 3.
Yes,
If you
ma'am.
achieved, so that's what I wanted to know. What was your criteria wherein you had to? So what was the percentage in 1? What is the percentage in 2? What is the percentage in 3?
Baseline is 40%. After first PDSA cycle, it increased to 47%, just 47%. After the second PDSA cycle, it increased to 65%. Then we found certain other factors. Then after simulation-based training and teaching and conducting micro scenario and addressing human factor, the incidence increased to 92%.
Okay. So in terms of result, so what was its impact on the number of length of stay in the ICU? Did it improve? And
Yes,
how many ventilator days did it improve?
yes, ventilator days, it improved. I will show again, ma'am. So invasive mechanical ventilator days, the mean mechanical ventilator days was 5. Median ventilator days was 5 in the pre-intervention period, and it decreased to 4 if we could talk about individual patient mechanical ventilator days. But in total, it was 625 in the pre-intervention period, and it decreased to 526 in the post-intervention period.
Okay. So did you involve the respiratory therapists and nurses, etc., in this study?
Yes, ma'am. Microbiologist as well as respiratory therapist, the physiotherapist of our ICU was also involved.
So whom do you think had the best compliance? The ICU physician, or or would I say, who was the most non-compliant?
Ma'am, if I talk about the knowledge part, initially the median knowledge score was 7 in the resident doctor, while it was
No,
6
not
in
knowledge,
the
compliance.
compliance. If we talk about the compliance, basically it was not differentiated between the resident as well as the nursing staff. It was in total compliance we looked after.
So who was the most non-compliant, I said?
Actually, we did not differentiated, ma'am, between the nursing fraternity as well as the resident doctor. We included, like, in general, it should be increased. And if we talk about the first PDSA cycle, the knowledge part was less in the nursing fraternity. And in the second PDSA cycle, the overall compliance was 65%, and it was almost similar. If it like the resident doctor compliance was also roughly around 70%, and the 65%, and even in the nursing fraternity, it was between 60 to 65%. So even the presentation of compliance, the audit report was presented by the nursing lead as well as the senior resident lead, the most senior resident doctor of the ICU. And the compliance was not very much different between the nursing population as well as the resident doctor population.
Thank you very much. Thank you very much.
Thank you so much, ma'am. Thank you so much, Dr. Anju ma'am and Dr. Indrani ma'am, for the wonderful discussion. Before proceeding further, I would like to welcome Dr. Tej K. Kaul, sir. Sir, please welcome.
Thank you very much. Thank you, every person involved in today's program. My best wishes to everyone, the younger generation. An excellent idea, and I love watching these programs. I've just joined it just 10 minutes back because I was just driving. All the best to everybody. All the best to everybody. Everybody, all the best.
Thank you, sir. You've been the driving force.
Thank you. Thank you. Thank you, madam. Thank you. Your grace. Your grace.
Thank you, sir.
Thank you, sir. So to proceed further, I would like to invite our next speaker, Dr. Bhushanam, sir. He's Associate Professor from AIMS, Bhopal. The topic would be comparison of intravenous dexmedetomidine and dignocaine in combination with parasternal intercostal block on post-operative analgesia in adult patients undergoing cardiac surgery, which is a prospective randomized study. So please welcome and proceed. Dr. Bhushanam?
He was here just now. I think must have logged out.
Okay. So should we proceed further, ma'am?
Next person.
We can move on. I'll just contact him.
Next person.
Okay.
Audible, ma'am.
Oh, yes.
Some disturbance from this end. Can I share, ma'am, screen?
Yes, please start sharing, Dr. Bhushanam. So please select your presentation on the extreme right-hand side.
1 second, ma'am. I'm not able to do this.
Yeah, we can
It's all
see.
right. I think you settle down.
Okay, ma'am.
Let's
Next
go
time.
to the next person. Bhushanam, don't worry.
Okay,
We
ma'am.
will include you a little later.
Okay, ma'am.
Just in the interest of time, we will go to the next.
Okay, okay, ma'am. So our next speaker would be Dr. Niharika Grover, ma'am. She is Assistant Professor from ESIS Medical College and Hospital, Faridabad. Her topic would be a randomized control trial comparing the analgesic effects of pectoral nerve block and erector spinae plane block for breast mastectomy surgery. Ma'am, please welcome and proceed with your topic.
Dr. Niharika, can you please start sharing your screen?
I'm trying to share.
Yes, please share. Do you need any help, Dr. Niharika?
I'm trying to share, but is it visible?
Ma'am, you can just click the share button which is there in the center, the green one with the arrow.
Yes, I'm doing it. But
Yes, if you click that and then just go to your folder where your presentation is.
Keep the folder open.
Your PowerPoint presentation should be open, ma'am.
Ma'am, it is open.
It should be open on your laptop.
It is
Then it
open.
will show automatically in the home screen. Then you can just click it. That's all.
It is open, ma'am.
You'll have to share and then click it. You
You
haven't
have to
shared
click
your
share.
screen. Share on the Zoom screen.
Is it visible, ma'am?
Yeah. Can you please make it full screen?
Yeah, sure. Can I start, ma'am? Can
Go
I
to
start?
screen. Yeah. Can you go
make
to
it full,
the full screen?
Dr. Niharika? From beginning, if you click the button, the extreme left-hand side top button from the beginning.
You have slideshow and you can go to the extreme left. Yeah.
Is it visible?
Not full screen again.
But on my screen, it is full screen.
Yeah. It's not getting clicked.
Yeah, it's not getting. Can you click on the table button, that table thing that is made on the extreme right-hand side down? You can click that also for full screen. I think in the meanwhile, we can invite our the next participant, Dr. Deep Sen Gupta.
Okay, ma'am.
Should I present my other class?
Yes, no
Doc-
problem. No problem.
Yeah, Bhushanam, you can go ahead and share your slides.
Yes, ma'am. Full, ma'am.
Yeah, we can have see your slides.
Thank you. Should I?
Yeah, please start, Dr. Bhushan. Your time starts.
Yeah. Good evening, everyone. Good evening, everyone. Title of my presentation is Comparison of Intravenous Dexmedetomidine and Lignocaine in combination with parasternal intercostal block on postoperative analgesia in adult patients undergoing cardiac surgery. It was a prospective randomized study. Coming to the introduction, cardiac surgery is often associated with more severe postoperative pain when compared to other major surgeries.
Ma'am,
So we need to explore and evaluate adjuvant therapies that can reduce the postoperative opioid consumption. Parasternal intercostal block has gained attention, especially regional anesthesia has gained attention during the ERAS era, and dexmedetomidine, a selective alpha-2 agonist, and intravenous lignocaine, it is very, very well established in the perioperative analgesic regimens across the anesthetic practices. So coming to my primary objective is to assess and compare the effect of intravenous dexmedetomidine and lignocaine in combination with parasternal intercostal block on postoperative analgesic requirements in patients undergoing cardiac surgery. My secondary objectives were to compare the duration of postoperative mechanical ventilation, postoperative analog score, and intraoperative postoperative hemodynamic stabilities. It was a prospective randomized study conducted over duration of 18 months in a tertiary care teaching hospital. My inclusion criteria were all adult patients aged 18 to 65 years undergoing elective cardiac surgery through median sternotomy using cardiopulmonary bypass and willing to participate in the trial. These are my exclusion criteria. And IHC Institutional Ethics Committee approval was taken, and study was prospectively registered in the CTRI. Coming to the methods, written informed consent was obtained from all participants, and they were also educated about the use of PCA pump and visual analog scale for assessing pain in the postoperative period. Standard NPO guidelines and pre-medication were given, and all patients received standard general endotracheal anesthesia. And after induction of anesthesia, all patients were given parasternal intercostal block. In this image, panel A is showing the needle insertion points from second to sixth intercostal spaces bilaterally, and panel B showing out of plane approach of giving parasternal.
We lost you, Dr. Krishnan. Can you hear, ma'am?
I think his
Signal is probably not good.
Bhushanam.
I think he has logged out, ma'am.
No, he's there, but I believe his signal is poor. We are unable to hear him. He'll have to log out and log in again. We can see him, but
Dr. Neha, Dr.
Yes, sir.
Neha had made a request last time also that, hello, can you hear me?
Sir,
I had made a request last time that proper
तुझा नाही आहे मला संदीप म्हणाला माझा आहे म्हणाला
that how to present online.
Sir,
And today we have very senior people, the faculty is presenting today, and they are also not clear about it. That is very sad.
yes, sir.
We
So
must
we
give
had actually given
beforehand to them that how it is to be presented, and the speaker should make, they should practice it earlier. This is my request.
Hello, ma'am. Am I audible, ma'am?
yeah, you're audible. Yeah, you're
Sorry, ma'am,
audible.
some disturbance, I think, ma'am.
So can we have all of these guys muted out, like so much
Yeah,
of
I know. I think
Is my screen visible, ma'am?
it is visible, but it is
no.
not on slideshow. Yeah, now it's on slideshow.
Yeah.
Should I continue from where I left, ma'am?
Yes.
Parasternal block. Yes, ma'am. So panel C showing a drug deposition in local anesthetic deposition between the lower end of upper rib and pleural position. And we can appreciate the pleural dipping down after the local anesthetic. Then randomization was done using computer-generated random number table with sealed opaque envelope technique. All measures were taken to ensure all IV syringes containing study drugs appear identical. And there were 3 groups in our study. Patients in group PD received parasternal block followed by dexmedetomidine infusion, loading dose of 0.5 micrograms per kg per minute per kg over 15 minutes, followed by 0.4 micrograms per kg per hour. Whereas patients in PL received parasternal block and lignocaine, loading dose of 1.5 mg per kg over 15 minutes, followed by 1 mg per kg per hour. Whereas saline group, parasternal PS group, parasternal block followed by saline infusion. So hemodynamic response defined either as a heart rate or mean arterial pressure more than 20% from baseline was treated with a bolus dose of IV fentanyl 1 microgram per kg. At the end of the surgery, infusion of study drugs were discontinued and patients were shifted to cardiac ICU. Patients were assessed at the time of first spontaneous eye opening, and if the VAS score was greater than 4, fentanyl 1 microgram per kg was administered intravenously. Patients were instructed to use a PCA pump after extubation, and PCA device was set at bolus dose of 15 microgram fentanyl with a lockout interval of 10 minutes and maximum 4-hour limit of 240 micrograms. And tramadol rescue analgesia is given if this maximum dose was reached and patient still complaining of pain. The study concluded first 24 hours after the postoperative period. Patients who required emergency re-exploration during the study period or remained on mechanical ventilator beyond 12 hours or died during the study period were excluded from the analysis. The sample size was calculated at 80% power and 90% confidence intervals based on previous study, and p-value less than 0.05 was considered statistically significant. This was my consort diagram. Over 130 patients were assessed for eligibility, and 108 patients, 36 in each group, were randomized, and out of that, 2 each in PD and PL group were excluded for various reasons, and 1 patient in PS group were excluded. Coming to the results, the demographic variables and the type of surgeries were among the groups were comparable, whereas postoperative analgesic requirements among the groups were also comparable. Even though the requirement was less in the study drugs, there was no statistical significant difference. Intraoperative fentanyl requirement from induction of anesthesia till beginning of CPB was significantly less in dexmedetomidine group. In fact, only 1 patient required 1 bolus dose of fentanyl in dexmedetomidine group. And duration of mechanical ventilation was not significant among the study groups, although it was less in the dexmedetomidine group. VAS scores were comparable among the study groups, and heart rate at various time points were also comparable, whereas mean arterial pressure following skin incision, sternotomy, sternal retraction were significantly less in dexmedetomidine when compared to other groups. And other parameters like duration of surgery, CPB, and total dose of tramadol required are comparable. Among inotropes, adrenaline requirement was significantly more in dexmedetomidine group. Coming to the discussion, we found lesser fentanyl consumption in both the study groups PD and PL, indicating the effectiveness of both the drugs. However, the difference was not statistically significant. This could be attributable to several factors, like we used multimodal analgesia regimens, and indirectly it indicates the effectiveness of our parasternal intercostal block. Even saline group has good results. Our findings were in agreement with the previous studies where the same drugs were used in lab chole patients for postoperative fentanyl requirements. And significantly less intraoperative fentanyl requirement in group PD, dexmedetomidine group in our study supports prior studies where the authors opined that use of dexmedetomidine effectively reduces the opioid consumption by its opioid-sparing effects and sedative properties. And various studies have also found the fentanyl consumption in post-cardiac surgery patients who received dexmedetomidine infusion in post-operative period. However, in our study, we used intraoperatively and we used along with the parasternal intercostal block. Our results in terms of shorter duration of postoperative mechanical ventilation were in agreement with the earlier studies. Although our findings didn't reach the statistical significance with that respect, they reflect a consistent trend supporting the dexmedetomidine role in enhancing recovery. Significantly, mean arterial pressure, less mean arterial pressure in intraoperative period in dexmedetomidine group could possibly explain the less requirement of intraoperative fentanyl in that group. So we have some limitations as well. It is a single center study with a small sample size, and we administered the same dose of drugs before and during the CPP, which could have affected the plasma concentration of the drug. And other potential benefits of the study drugs like dexmedetomidine in post-cardiac surgery patients, it has shown some effects in atrial fibrillation and postoperative cognitive dysfunctions that we have not evaluated. And we have not included CABG patients in our study group because most of the CABG patients in our institute were carried out off-pump CABG. To maintain uniformity, we have not included. So our results are not uniformly applicable to all cardiac surgical patients. To conclude, in combination with a parasternal intercostal block, both dexmedetomidine and lignocaine have comparable postoperative analgesic requirements in patients undergoing cardiac surgery, and intraoperative fentanyl requirements were significantly less in dexmedetomidine group, and no statistical significant difference in terms of postoperative duration of mechanical ventilation and VAS scores we observed in our study, and heart rate was comparable at all study time points, whereas mean arterial pressure was significantly less in dexmedetomidine group. These are my references. Thank you, ma'am.
Thank you, sir. Now over to Dr. Anju ma'am and Dr. Indrani ma'am for the discussion.
Thank you so much, Dr. Bushnab. I wanted to ask you,
Yes, ma'am.
like, what was the timing of your parasternal intercostal block?
Immediately after induction, ma'am, we induce the patient with routine cardiac induction. After induction, ultrasound guided out of plane approach we used for parasternal block, ma'am.
And you started the infusion simultaneously.
Yes, ma'am. Initially bolus dose followed by continuous infusion throughout the surgery. Just before shifting out of OT, we switched off the infusions, ma'am. Dexmedetomidine or lignocaine or this.
So what?
When
Why
did you
did
switch off? Sorry, I didn't hear you. When did you switch off?
Once skin closure is done, just before shifting to ICU, ma'am. We
Okay.
continued
Then
throughout the
the
surgery, ma'am.
patient was on patient control analgesia when they wake up.
Yes, ma'am. In post-operative period, once the patient extubated, then we will keep an patient-controlled analgesia, ma'am.
And what about from the time patient is shifted to the extubation?
Yes, ma'am. Once the patient is shifted to cardiac ICU, a little sedation in terms of midazolam 20 microgram per kg per hour infusion was started, ma'am. Once the eye opening is achieved, we will see the first eye opening PC VAS score, ma'am. Then after extubation, we instruct the patient to use PCA pump. Our study period lasted for first 24 hours in the post-operative period, ma'am.
But then you have looked at intraoperative fentanyl requirements, but in the post-op you switched over to tramadol, if
No,
I'm
ma'am.
correct.
Fentanyl only, ma'am. PCA pump, we
I
usually
did see a slide saying
that tramadol
tramadol.
is for actually
Rescue.
rescue, ma'am. Actually,
Rescue.
we put a 4-hour limit of fentanyl consumption, ma'am, in PCA pump of 240 micrograms, ma'am. So
Okay.
if beyond that, if patient still requires rescue analgesia, hardly we used in 1 or 2 patients only, ma'am. Out of 100 patients, rescue analgesia was used, not significant, ma'am. 1-2 patients.
So in all your groups, in all your 3 groups,
Yes, ma'am.
what was the total opiate consumption in those 24 hours?
24 hours में it was not significant, ma'am. Around 240.
No. What was the total opiate consumption? Was
Actual
it
consumption.
yeah.
Yes, ma'am. It varies around 300 mics like that, ma'am.
100
So
mics,
then
278.
that will
Yes, ma'am.
affect the study, right?
No, that only we
And
calculated, ma'am.
the
Post-operative.
confounding, factor.
No, ma'am.
And
Post-operative.
what about the first rescue analgesia? Which of these 3 groups needed the first rescue analgesia?
Rescue analgesia was because patient-controlled analgesia. Whenever the patient is having pain, he or she used to use the PCA pump to control, ma'am. Beyond that, only one patient required in dexmedetomidine group tramadol, ma'am. So it was not coming significant, ma'am. Out of 100 patients, 108 patients, hardly 1 or 2 patients only required rescue analgesia, which is beyond 240 mics in a 4-hour interval, ma'am.
The other, because you didn't take into consideration CABG patients,
Yes, ma'am.
you have taken into consideration valvular heart
All
disease
surgeries, any kind of cardiac surgery.
and congenital heart disease, you've taken into consideration.
Adult
But
patients.
when you have to compare the hemodynamic stability of the patients who are receiving in these 3 groups,
Yes, ma'am.
the other confounding factors like pulmonary hypertension, acidosis, hypoxia, hypercarbia,
Yes, yes, ma'am.
all those factors also will come into play.
That's why
So did you discount for all these things?
yes, ma'am. That's why the hemodynamic stability is only our secondary outcome, ma'am. Secondary objectives, ma'am. It is not the primary thing. And
What about patients who could have got extubated on table, like ASD, VSD?
on table, we won't extubate, ma'am. Any
You never extubate an ASD, never extubate.
all adult patients we will see drying those things, ma'am. All the distribution of cases are comparable among the groups, ma'am. He included ASD, VSDs, everything, but they were comparable among the 3 groups, ma'am. I have shown in first table the distribution of.
So was there any difference in the extubation duration? I mean, the duration of ventilation and Were there any early extubation in any of the groups?
Dexmedetomidine groups early extubation was found, ma'am, but that was not statistically significant, ma'am. Although we found a lesser duration of mechanical ventilation and lesser postoperative opioid consumption in study groups, that we found not statistically significant, ma'am. Probably we have given block also, ma'am, parasternal block. What was
the agent, what was the drug and the volume used in the parasternal block? Do you think biases could have come into your study?
No, ma'am. All three groups parasternal block was given, ma'am.
I understand, but
yes, ma'am.
what was the drug used?
Bupivacaine, ma'am.
Bupivacaine.
0.2%.
Okay.
0.25% bupivacaine.
0.2%. Yes,
And
ma'am.
how much of volume?
40 ml, ma'am, total, ma'am.
40 ml either side.
Yes, ma'am. Total 10 injections, ma'am. 4 ml in each space of 10 interspaces, around 40, total 40 ml, ma'am.
So did you find any complication, adverse effect in any of your patients?
During block, ma'am? No, ma'am. It was given.
No. Okay, during block, that is different. In
Yes,
all
ma'am.
the three groups. Because with dexmedetomidine and
Yes,
surely I would expect,
Yes, ma'am. Because of sympatholytic activity, the mean arterial pressures were significantly fell down during skin incision. So it helped us to maintain to attenuate the response, ma'am. Skin incision, sternotomy, sternal retractor placement, usually associated with so much of response, ma'am, which we require so much of opioids during intraoperative period. Because of these drugs, that was attenuated well, ma'am. So
did you give opiates before skin incision and sternotomy?
Routinely we will give, ma'am. In this study, we have not given, ma'am. That's what we assessed, ma'am. In fact, in dexmedetomidine group, out of 35 patients, only one patient required one bolus dose of fentanyl required.
Fentanyl. So do you feel that
Much better, ma'am.
dexmedetomidine should be routinely used in
Yes,
open heart surgeries?
Yes, ma'am. Yeah, earlier I have conducted only with parasternal block, ma'am. Now I added IV infusion also to see the effect, ma'am. I have published that article, ma'am, in Journal of Cardiac Surgery.
But what really I can't understand is, see, in one group you have added dexmedetomidine. One group, all of them have received the parasternal block,
Yes, ma'am.
right?
Yes,
That
ma'am.
is the common denominator.
Yes, ma'am.
And one of them has dexmedetomidine added, one of them had lignocaine added,
Yes,
and
ma'am.
one of them had saline added.
Yes, ma'am.
So, so there was, you did not have, none of them was superior to the saline group.
That's what, ma'am. Among those two study groups, dexmedetomidine, lignocaine, both found to be requiring less analgesic requirement in the postoperative period.
But it was not statistically significant.
Yes, ma'am. That's what, ma'am.
Yeah, so that is why I said. So
that
you
I
did
put
not
in
find
limitations.
any big advantage.
That's what, ma'am. Our sample size is a limited single center study. That's what I put in this thing also, ma'am. One of the limitation, ma'am. We are.
Okay.
I have
Because you
searched
ran through your
patients.
limitations, we couldn't even read your limitation.
Achha, ma'am. 100 patients only we did, ma'am. That the trend is towards reduction in dose of postoperative opioid consumption and earlier extubations, especially with respect to dexmedetomidine group, ma'am, in combination with parasternal block. So
okay, I would have been probably even more happier if you can continue the study.
Yes, ma'am. Yes, ma'am.
And have a multicentric study.
Yes, ma'am.
And also include, cortisol levels.
Yes, ma'am. Yes,
have cortisol levels or, cytokine or CRP levels added to this.
Exactly,
So
ma'am.
that will actually add weight to your study.
Yes, ma'am. Sure, ma'am. Sure, ma'am.
So much.
Thank you so much.
Thank you, ma'am. Thank you.
Thank you, ma'am. Over to the next speaker, Dr. Niharika, ma'am. Can you please open your slides?
No, I don't.
Dr. Niharika, you'll have to unmute yourself. Yeah.
Can you all see the slides?
We can, but it is the last but one slide. So you'll have to go to the first slide and go on to full screen.
Visible?
Yeah,
Visible.
I think you can start with this as well.
Good evening all. Today I'll present a randomized controlled trial comparing the analgesic effects of pectoral nerve block and electrospinal block for modified radical mastectomy. Usually modified radical mastectomy is done under general anesthesia with multimodal analgesia in the form of intravenous opioids, NSAIDs and regional blocks. However, the incidence of chronic post-surgical pain and long-term opioid dependence remains 29% and 11%. So in this study, we compared pectoral nerve block and erector spinal block as they both are known to reduce the use of opioids, reduce the complications of paravertebral block and epidural analgesia, provide excellent analgesia, and decrease the stress response to surgery and the progression of malignancy. Also, there are very few studies which compare two blocks for the analgesia in breast surgeries.
Move your
Dr.
slides,
Niharika, you
please.
will have
Niharika,
to
can you?
manually select the slides because we can't see otherwise.
You'll have to move your slides. Go on the scrolling bar, yeah, on the side, on the left side, and scroll them down.
Is it visible now?
Just the first slide.
Okay, just okay.
I think next time around we can have them record their entire thing and just bring them for question and answers. You know. Really, it's been 1 hour and 2 people have presented till now.
Mama, my slides visible. I can play it for her.
Yeah, please
Yeah,
start.
please go ahead.
Dr. Niharika, please go ahead.
Can you see them?
See. Yeah, we can see. Please start speaking here.
From the beginning or can I continue from there?
Yeah, you can start.
Full screen कर लो, देखो तो।
So our aim was to compare the analgesic effects of both the blocks for modified radical mastectomy. We studied the total rescue analgesic consumption in first 24 hours of surgery as our primary objective. Also, we assessed the post-operative pain using the numeric rating scale at rest and at movement at 30 minutes, 2 hours, 4 hours, 6 hours, 8 hours, and 24 hours after surgery. All the patients who had NRS having more than 5 post-operatively were given a rescue analgesic tramadol 50 mg tramadol along with it intravenous fentanyl 30 micrograms bolus as well. This was a double-blind randomized controlled trial from January 2023 to October 2024 after the ethical committee clearance and CTRI registration. 60 patients were randomized and allocated by the sealed opaque envelope method. An ultrasound-guided facial plane block for analgesia was given in 30 groups each of modified pectoral nerve block and electrospinal block. All the patients received general anesthesia, and after the induction, they were given a modified pectoral nerve block where or electrospinal block. In modified pectoral nerve block, 30 ml of 0.25% levodopa was given total, where 20 ml was given as between the pectoral minor and sedative sedative, and 10 ml was given between the pectoralis major and minor under ultrasound guidance. In electrospinal block, 20 ml of 0.25% levodopa was given in the parasagittal orientation 3 centimeters lateral to T6 or T7 spinous process after local infiltration from cephalic to caudal approach, and drug spread was seen lifting the erectospinal muscle of the transverse process. All the patients with the age group of 18 to 65 years, ASA1 and ASA2, posted for elective modified radical mastectomy under general anesthesia were included in the study. All the patients who had contraindications for regional anesthesia, any bleeding problems, or patients on chronic analgesics were excluded from the study. We studied the hemodynamic parameters like heart rate, systolic and diastolic blood pressures, 30 minutes prior to shifting to the operation theatre. Total rescue analgesic, total amount of intraoperative fentanyl, and NRS at rest and movement were assessed at 30 minutes post-operatively, 2 hours, 4 hours, 6 hours, 8 hours, and 24 hours post-operatively. All the patients received intraoperatively injection paracetamol 15 mg per kg IV and fentanyl 30 micrograms bolus after the induction dose of 2 mics per kg if there was a rise in
Excuse me, madam.
intraoperative. Hello?
Excuse me, madam. Little louder.
Okay, sir. All the patients received injection paracetamol 15 mg per kg IV intraoperatively along with fentanyl 30 micrograms bolus if there was any rise in systolic BP more than 15% of the baseline. Post-operatively, every patient received paracetamol 15 mg per kg IV thrice daily and fentanyl 30 micrograms bolus was given if NRS was more than 5. Any patient who reported NRS more than 3 were given tramadol 50 mg IV. Total 65 patients were assessed for the eligibility, out of which 5 were excluded because of not meeting the inclusion criteria. 60 were randomized, allocated, followed up, and analyzed. There were no dropouts after that. Standard statistical analysis was done accordingly. All the baseline characteristics were similar in both the groups, except the duration of anesthesia was found to be statistically significantly more in the ESP group. Hemodynamic parameters of all the patients preoperatively were similar. We found that the additional dose of fentanyl given in ESP group was more. However, the result was not statistically significant. Total tramadol consumption was significantly high in ESP group rather than fentanyl. NRS at rest was uh, significantly high at 4 hours and 8 hours in ESP group. At NRS at movement was statistically significantly high in ESP group at 2 hours, 4 hours, and 8 hours. Post-operatively, hemodynamics were measured, which showed a statistically significant difference, but not a clinically significant difference in systolic blood pressures and diastolic blood pressures at 2 hours, 4 hours, and 6 hours. There are various studies which support the results found in our study. One of the study was done in 2019 with a sample size of 64 in AIIMS New Delhi, which report the similar results. There are few other studies which report the similar studies. The limitations pertinent to our study were that time to request for the first rescue analgesic was not assessed. Longer follow-ups more than 24 hours were not done. It was a single center study and had a small sample size. Also in a PEG block, surgeons had an interference of a surgical field, and in ESP block, longer duration of anesthesia was reported. Thus, to conclude, modified radical mastectomy ultrasound guided PEG block is superior to ESP block in terms of pain intensity scores and opioid requirement. Thank you.
Thank you, ma'am. Over to Dr. Anju ma'am and Dr. Indrani ma'am for the discussion.
Thank you, Dr. Niharika. Were all the blocks given by the same provider?
Ma'am, we were two persons who gave the block, but both of the two persons had given more than 25 blocks each before conducting the study.
Was the person assessing the pain blinded to the procedure, to the blocks which was given?
Yes, ma'am. The assessor was not knowing and the patient was not knowing because the block was administered after general anesthesia.
And in your inclusion and your exclusion, were there any exclusion criteria?
Yes, ma'am. It's patients who had the bleeding disorders, patients who were on the chronic analgesics, and patients who had any contraindication for regional anesthesia were excluded from the study. They
What
included
about obese patients?
Ma'am, there was no criteria of BMI in our study. All the patients, irrespective of BMI, were included in our study.
And other
Any other biases that you found or confounders that you think were there in your study?
Actually, sometimes confounding factor was not much. It was one man has only said that obesity in BMI, if in obesity BMI was more, we didn't give more drug in mg per kg. We fixed the standard doses, and those standard doses were given 30 ml in TEC and 20 ml in ESP. So that can be a limitation. And plus, some resistance was found by the surgeons while providing tech block because they said that the post-operatively or intraoperatively actually they don't get the proper fluids. So there was some resistance, but eventually that is why we took longer time to complete the study, but we completed.
how do you justify your result? Because modified PEC block,
Yes, ma'am.
I understand you're giving analgesia to that area where you're doing the surgery, right?
Yes, ma'am.
Whereas ESP is even more broad, it takes a thoracotomy pain.
Yes,
The
ma'am.
entire thoracotomy pain is being addressed by the ESP block, isn't it?
Yes, ma'am.
Plus, your intercostal nerves are also blocked
Yes, ma'am.
in your ESP.
Yes, ma'am.
Okay.
Yes, ma'am.
So, however, your result is on the contrary. Your
Yes,
result is
ma'am.
saying PEC blocks are better rather than ESP block. So, can you justify this?
Ma'am, that may be because of the complete not blocking completely the lateral pectoral nerve or medial pectoral nerve. Because of that reason, we may found that that ESP was a poor performer in front of pec block. Because and also pec will cover the anterior. Actually, intercostal nerve has been covered, can be covered by ESP, but probably our space was also T6 and T7 where we had given ESP. Probably it spreads by up two segments up and two segments down, but maybe it is possible that it has not spread to that extent above that till T2. That is the reason that it is not.
I feel that probably your sample size was not enough.
Yes, ma'am. That I have mentioned.
Anju, you can comment on that.
Yeah. I was actually about to say that only. The number of patients needed to treat for this particular primary outcome, I believe were less, so that you could actually pick up a clinically and a statistically significant
Yes,
difference.
ma'am, I agree with that, but I got the sample size calculated by using the confidence interval of 95% and power of 80% with alpha error of 0.05%. And according to the study which I quoted only first in the discussion.
Can you
So
do
the
a
sample
pilot
size
trial?
ESP was given at what level?
in our study it was given at T6 to T7 level.
That
T6 or
could be the
T7.
reason.
That is what I'm saying,
That
ma'am.
could
It
be the
was,
reason
yeah,
why you're getting less,
yeah,
because
because it
a
has to be up
modified
a bit.
ESP should be T3 or T2.
Yes, ma'am. You should be a bit above. That is why
Yes,
we are
it
not
should
getting
be
the proper
above.
data. Yes, ma'am.
For you
Then
to
that's
get
a
a good,
methodological issue. Yeah.
Yes, ma'am.
So it kind of brings in a methodological issue as well.
Yes,
isn't
ma'am.
it? So
Yes, ma'am. But it was like T5 to T7 only it was planned, but practically it was given between T6 and T7 only. T6 or T7, whatever space we found better.
don't you think what do you think a combination of both the blocks can have a better effect, or
Uh,
you don't think so?
Ma'am, they definitely may perform better if we give both the blocks together, but according to our setup, but it would be very time consuming to get all the two blocks together to be given to a MRN patient.
Because you
Because of,
need axillary clearance also, no, for
yes,
MR.
ma'am. Yes, ma'am.
So that's why I asked you this question.
Yes, ma'am.
All right, thank you so much.
Thank you
Thank
so
you, ma'am.
much.
Thank you, ma'am. Now over to the next speaker, Dr. Deep Sengupta. He's consultant anesthesiologist in AIG Hyderabad. His topic would be a prospective comparative analysis of the efficacy of frailty score compared with initial
Frailty score.
frailty index, compared with the initial Glasgow Coma Scale pupil score and subdural hematoma in elderly score in predicting outcome of operated chronic subdural hematoma patients.
Good evening, esteemed chairpersons, respected seniors, and dear colleagues. Madam has already told the title of my study. Proceeding with the introduction, so chronic subdural hematoma is a very rapidly developing epidemiological problem in neuroanesthesia and neurosurgical group. The incidence is going high day by day, with 58 to 127 per 1 lakh year per 1 lakh per year reported in one of the recent studies. Frailty per se, it is defined as a clinical state of increased vulnerability against small stressors, which results from decreased functional reserve across multiple physiological systems as a result of aging. Paucity of information regarding the effect of a patient's underlying comorbidities on CSDH prognosis was the main driving point to conduct this study. The studies which are there, however, are mostly retrospective, and to date, no study has compared the effect of frailty with the initial GCSP score and the subdural hematoma in elderly score for predicting outcomes in operated cases of chronic subdural hematoma. Coming to the scores per se, so GCSP score, it is derived from Glasgow Coma Scale and subtracting the pupillary reactivity score. So in case both the pupils are unreactive to light, the score is given 2 and the GCS is subtracted from this. For example, if a patient is having a score of say 13, GCS of 13, and both the pupils are not reacting to light, then the GCSP score would come out to be 13. The advantage of GCSP over GCS is that GCS, the lowest reading which we get is 3, while in GCSP we can get a score up to 1. And the studies have shown that the mortality rate and the unfavorable outcome significantly increases to 74% and 90% and making it a better predictor. The subdural hematoma in elderly score, it was published in the year 2019, and it was used to predict outcome, particularly mortality in the elderly people. They had 3 major criteria: age in years, whether it is less than 80 or more than equal 80 years, admission GCS score 3 to 4, 5 to 12, 13 to 15, or SDH volume, which they computed through ABC by 2 formula through a neuroradiologist. And the scores were given from 0 to 4. So at the score of 0, the 30-day mortality rate was predicted to be 0. At score of 1, it was 3.2%, which progressively increased to 13%, 32%, and 95% as the score increased. Coming to the modified frailty index. So frailty per se has come into vogue quite frequently now, and there are multiple scores published. This is one of the most comprehensive scores which is there. It takes into account 11 points, and all these 11 points are given a score of 1. And we have to divide the total score of the patient with this 11. Now the patient is considered to be frail if the score comes to be more than equal to 0.27. For example, if the patient gives history of diabetes, respiratory problem, and a congestive heart failure, the score would be 3 out of 11, and then you have to score the frail patient. And then the outcome scale, which we are using, GOSE here, Glasgow Outcome Scale Extended, which grades from 1 to 8, 8 being upper good recovery, while the score of 1 denotes a mortality. Aim of the study, it was to perform a prospective comparative analysis between MFI-11, GCSP, and SHE scores for predicting outcome in operated cases of CSDH. The primary objective was to see this outcome assessed via GOSE at 30 days post-surgery, while the secondary objectives were the total length of hospital stay, ICU stay, and any redo surgery within 30 days. It was a prospective observational study. There was no blinding or randomization done. And we did the study from June 21 till December 24. The inclusion criteria were we only included unilateral chronic subdural hematoma patients, elderly patients, that is the age of more than equal to 65 years, and all the patients were admitted in a neurosurgical ICU. Exclusion criteria being refusal of consent. We did not include bilateral or acute, subacute, or acute or chronic SDH components, and we did not include any patient with history of bleeding diathesis. We totally assessed 162 patients in almost 3.5 year time period, and out of that, 25 patients were excluded, and finally we included 137 patients. An informed, valid, and written consent was obtained prior to this. Baseline demographic characteristics, GCSP score at admission, frailty score, and SHE score were recorded. Hematoma volume was computed via ABC/2 formula with the help of a neuroradiologist. An outcome was assessed using GOSE scale at discharge and at 1 month post-surgery, and baseline investigations were recorded. The sample size was determined based on the study done by McIntyre et al. In their study, they compared the GCS with the final outcome in SDH, and to detect a difference of at least 1 with a power of 80% and a significance level of 5%, the statistician gave the sample size required to be 137. A brief overview of the results. So mean age was 69 years. So majority of them were male, 76%. Most common mechanism of injury was fall, 62%. History of antiplatelets or anticoagulants, it was seen in 28% of patients. Burhole was the most common modality of surgery, which was 81% versus mini craniotomy, which was done in 9.5% patients. The median GCSP score at admission was 15, with the IQR ranging between 7 to 15. The median SHE score was 1, and median frailty score was 0.09. At 1 month, the GOSE was 8. The median ICU stay was 3.5, hospital stay was 5.4 days, and the reoperation event was noted in 9.5% persons. Coming to the main primary outcome here. So we dichotomize the data. So between the good GCSP of more than equal to 13 and the GCSP of less than equal to 12. SHE score less than equal to 1 versus more than equal to 2, and frailty between frail versus non-frail patients. That is a score of less than equal to 0.18 versus a score of more than equal to 0.27. So in this, we found that in GCSP, age, ICU stay, hospital stay, and the outcome both were comparable, and there was no statistical significance. While with SHE score, only the ICU stay was statistically significant. Between a score of less than equal to 1, it was 3 days, while in score which was more than equal to 2, it was 10 days. But when we compared the frail versus non-frail patients, all the components, age, the duration of ICU stay, the duration of hospital stay, as well as the outcome were statistically significant. It was 66 years versus 77. Mean stay of ICU stay was 2 days versus 7.6. Hospital stay 4.3 versus 9.2 days. And GOSE score was 7.75 versus 5.6. So frailty is an emerging concept that aims to quantify the cumulative effect of comorbidities to more accurately prognosticate outcomes. In this study, we found that frail patients as compared to the non-frail counterparts were older in age, they had a longer stay in ICU and hospital, and they had poorer outcome at 1 month post-surgery. Frail patients, they experience physiological decline and possess a decreased functional reserve, both of which increase the vulnerability to adverse health outcomes. Initial GCS following CSDH was thought to be the factor with the highest prognostic utility till now. Incorporation of frailty assessment into the SHE score led to increased accuracy of outcome prediction in CSDH patient cohort in our study. The strength of the study was a prospective design and inclusion of only unilateral chronic SDH patients, while the limitations being it being a single center study, and we included both mini craniotomies and burr-hole evacuation in this. So to conclude, frailty as assessed by MFI 11 index is a superior predictor of outcome at the end of 1 month post-surgery compared to GCSP score and SHE score. Frailty assessment is a useful prognosticating tool for post-operative course in these patients. Thank you.
Thank you, sir. Over to Dr. Anju ma'am, our chairperson, and Dr. Indrani ma'am, our chairperson, to go ahead with the discussion.
Thank you, Dr. Deep. What I have, I'm still trying to figure out is that how does frailty score compare with your Glasgow coma scale?
So, ma'am, frailty score and Glasgow coma scale. So, whenever we see a patient, we receive a patient, we
that I understand, but then what I'm trying to say is frailty score looks at different parameters, whereas GCSP score looks at an absolutely different kind of assessment, right? So how do they kind of compare with each other? is something that really needs
Yes,
to be
ma'am.
understood. Yeah.
GCS looks at the level of consciousness of a patient, while frailty looks at overall the level of frailty in that patient with multiple parameters. They do not compare with each other, ma'am. No.
But then your study is only saying that it is
The comparative analysis of the
analysis,
efficacy
right?
each score against each other. So, that is where perhaps uh, they would complement each other, but they would not be, taken against each other because
No,
they're looking at, yeah,
you're looking at outcomes.
Outcome. We're
at
comparing
the
the
end of the
outcome. GCS
day.
versus outcome, frailty versus outcome, and the she-score versus outcome. And that what we were looking to compare,
So, had
ma'am.
you done some kind of, more
No,
of
but
a
what again? What Dr. Anju Garewal is saying is also right. See, on one side you're looking at a GCS score, and the other side you're looking at the frailty, and the other one you're looking at she score. Okay, somewhere down the line, the she and the frailty may kind of overlap a little bit. Okay, but how does GCS minus what is that
GCS P
pupil?
score, ma'am.
That
Activity
you
score.
know that somewhere does not fit. Second thing, what I observed was the outcomes. When you see, you are comparing burr hole with craniotomy,
Mini craniotomies, yes.
mini craniotomy. Burr hole outcomes versus mini craniotomy outcomes are going to be different. It's
That
not going to be the same. Again,
that would
what about anticoagulation? Were they receiving anticoagulation? All of them.
So yeah, ma'am. So that we included in the study that were 28% of the patients. And the burhole versus mini craniotomy part, we also understood, ma'am, and we included it as a limitation. But because the sample size required was quite high and to cover it, and because we were not including the other components like bilateral or acute and chronic, so this we included to complete the sample size. But yes, we included that as a limitation factor, ma'am. It should have been more streamlined with only burhole or only mini craniotomies to have a more robust
That
data.
would have actually
Yes,
compared, in one level playing area,
right, ma'am.
that would have been. And another thing which you said was there's no mortality at all.
So, ma'am, we should
So,
look.
which means your subdural hematoma volume
was less.
was less.
So,
Your
ma'am,
GCS score was higher.
so, ma'am, so we
That's what
looked.
I could, kind of interpret.
So, all the data we looked at was at the 30th day, ma'am, post surgery, and up to 30th day, we didn't have any mortality. Now, all these patients we included were chronic as unilateral chronic SDH, ma'am.
Which
There
was
can
the
be a
biggest.
bias, in your patient selection
And
coming into your
considering
studies.
they were all elderly and they had a condition which was done only for the elderly patients. We had to had the age group fixed,
Were there a midline shift
ma'am.
in all of them? Could you kind
patient,
of assess how much is the midline shift, and was there any, what do you call exclusion based on that?
line shift and all those data was there. We had the CT scans and those
So,
things were
was there any
included.
exclusion factor?
And
Means
that
if there's a huge hematoma, okay, then the outcomes are different
no,
for huge hematomas.
based on
Those
the
with pupil unequal, both are unequal, and GCS is
exactly.
low.
So that's why we
Outcomes are going to
included.
be little different.
That's why we included the GCS score, ma'am, to incorporate these factors. Suppose a patient is coming with a big hematoma, so the GCS will get affected in those patients, and therefore they will have a role in the outcome. Similarly, if the hematoma is large, the she score would get affected, but the frailty score won't get affected. So all the components.
So why did you decide about what made you decide about more than 0.27 and less than
So,
0.18?
ma'am, that is the modified frailty index, the journal, the article which published that score, they defined it that if the score is 0.27 or more, then the patient should be considered as flared. It was the definition given by the study,
Okay.
ma'am.
All right. So based on definitions.
Yes, ma'am. The frailty definition is based on that. All the mortality scores were based on that. So this is precisely the reason we compared GCSP, included the GCSP also, ma'am, because some patients may present with a poor GCSP score, but they may not be frail, while some patients who may present with a good GCS, but they may be significantly frail. And then we compared all of them with the outcome.
What I
a
would
sensitivity
actually,
is, yeah, sorry, ma'am. A
what I would,
sensitivity, sorry.
yeah,
Go
yeah,
ahead,
go
ma'am.
ahead, go ahead, go ahead.
A sensitivity specificity analysis would have been a better idea to look at your data,
Yes, ma'am.
considering each of them performing on what kind of level. That is what I feel.
Yes, ma'am. Actually,
Yeah,
ma'am, we
okay.
recently completed the thing, and the complete statistical analysis is to be done with a proper statistician. We are actually looking to do a logistic regression with the interaction term testing done to compare that, because it's a binary data, unilateral, sorry, this plus that. So we are planning to do a more robust data analysis, as you correctly pointed, ma'am. Yes.
Okay. So, because you said from your inference, the GCS and the SHE score is less predictive.
Yes, ma'am.
Do you think we should uniformly have this frailty score as the
Yes, ma'am. I believe
as
frailty
as a guide?
Yes, ma'am. I believe frailty should be taken into account. So suppose we are receiving a patient who is
In your
80
preoperative stratification.
preoperative strategy, ma'am. Because if a patient is say 80 years old and that patient may not present with a poor GCS or a large hematoma volume or something, but they may be significantly frail. And frailty per se definitely impacts the outcome much more compared to the presenting GCS or GCSP score or the SHE score. So yes,
What I would
frailty plays a
also
very big
want to
role.
say is, if the frailty score is high, not only should it have an outcome on subdural hematoma, it will have an outcome in any major surgery.
Exactly, ma'am. Very true. Yes.
It's not specific to
No.
neurosurgery.
No, ma'am. No. But to make a more streamlined approach, we included only chronic subdural hematoma in neurosurgical population group. But yes, frailty per se affects whole body in total, in general. Yes, and everything should get affected by that.
That's right. So you feel that this should be incorporated in your pre-op, so
Assessment,
that
yes.
you can kind of allocate an ICU bed or
From all times. So from
book
a
a bed for
holistic
the
care
patient.
point
Yeah.
of view. Yes, ma'am.
Thank you.
Thank you, ma'am. Thank you.
Thank you, ma'am. We would like to go to our next speaker, Dr. Saurav Trivedi, sir. He is Assistant Professor in AIMS Bhopal. His topic would be efficacy of 6% hydroxyethyl starch and 2% lignocaine in reducing the pain of propofol injection, a randomized placebo-controlled trial. So please welcome and proceed with the topic.
Is it visible? Hello?
Not
Yes.
yet. Not yet. Yeah, now yes. Yeah, you can go to full screen.
Okay. Good evening, everyone. My topic.
No, it is not visible. Please share your screen again.
Sorry. Now fine? Hello?
Yeah.
Yes.
Is it visible now?
Yes,
Yes,
please go ahead.
Dr. Saurav, please go
Good
ahead.
evening, everyone. My topic is efficacy of 6% hydroxyethyl starch and 2% lignocaine in reducing the pain of propofol injection. It was a randomized placebo-controlled trial. So, coming to the introduction, as you all know, pain of propofol injection is very common with an incidence about 22 to 80%, and it's very distressing to the patient, and it leads to discomfort and anxiety in the operative period. Various solutions which are available for this problem are the pre-administration of 2% lignocaine, which is commonly used, ketamine, opioids, NSAIDs, but still the pain of propofol persists. The main mechanism through which the pain of propofol occurs is the activation of kallikrein-kyrene cycle and release of bradykinin, and of increase in the permeability of the vascular endothelium. Further, the propofol reacts with these free nerve endings and causes the pain. So coming to the hypothesis, 6% hydroxystyl starch, as we all know, it inhibits endothelial membrane activation by various substances and molecules. And by modifying the endothelial junction, it decreases the permeability. Thus, we hypothesize that 6% HES can be used to reduce the pain of propofol injection. Coming to the research question, thus, pre-administration of 6% HES reduces the pain of propofol injection more effectively than 2% lignocaine as well as propofol. Coming to the aims and objective, the aim of the study was to compare the efficacy of pre-administration of 6% HES and 2% lignocaine as compared to the placebo in the prevention injection. The primary objective was to compare the proportion of patients with no pain on propofol.
I'm an RSACP right now.
The secondary objectives were to compare the pain scores, the proportion of patients with mild, moderate, and severe pain, and to observe any change in the pre and post-induction hemodynamic variables in the study groups. So it was a randomized placebo-controlled trial. After ethical clearance and CITR registration, patients were recruited into the study. Sample size calculation was done by using G-Power3 software for Windows and using the data from study done by Mr. et al. A sample size of 103 participants was required to achieve an alpha error of 0.05 and 95% as a power of study. And for accounting for loss to follow-ups, approximately 10%, we totally took a sample size of 339 patients. So totally 348 patients were assessed for eligibility. The inclusion criteria were age group of 18 to 70 years, ASAPS 1 and 2, and patients undergoing elective surgery under general anesthesia with propofol as induction agent. A total of 9 patients were excluded, 4 didn't met the inclusion criteria, and 5 declined to participate in the study. The participants were randomized into 3 groups by computer-generated random number of table with a block size of 3, and seal envelopes were used for the concealment of the study group allocation. In group HES, they received 100 ml of 6% HES, followed by an induction dose of 1% propofol. The control group, that is the lignocaine group, received 100 ml of normal saline, followed by induction dose of 1% propofol, which was pre-mixed with 2 ml of 2% lignocaine and 20 ml of syringe. And in the placebo group, 100 ml of normal saline, followed by induction dose of 1% propofol. All the 3 groups were analyzed for the study outcomes. The pre-administration drugs were prepared by an assistant who was not at all involved in anesthesia induction and the pain assessment. Both the patient as well as the investigator were blinded to the randomized group allocation and study drugs. All the drugs were prepared and stored at room temperature and were used within 10 minutes of formulation. The 100 ml of HES as well as normal saline were administered slowly over a period of 5 minutes, and propofol was injected at the rate of 0.5 ml per second till the loss of verbal response of the patient. Coming to the assessment part, the pain on propofol injection was assessed by a blinded investigator before the loss of verbal response of the patient on a score of 0 to 3. 0, no pain, mild, 1, mild pain, which was evident on questioning to the patient after 10 seconds without obvious discomfort. 1, moderate pain, which was self-reported by the patient within 10 seconds with some discomfort. And 3 was severe pain. With the patient was accompanied by withdrawal of hand, facial grimace, rinsing, howling, and crying. Any hemodynamics instability was also noted. Analysis was done. The data was accumulated and analyzed using SPSS 24 software. Quantitative data were expressed as mean and standard deviation and used compared using analysis of variation. Categorical data were expressed as numbers and frequencies and was analyzed using chi-square test. A p-value of less than 0.05 was considered statistically significant. The demographic parameters were comparable between the 3 groups. The proportion of patients with no pain of propofol injection was significantly higher in HES group as compared to the lignocaine and the placebo group. The proportion of patients with moderate and severe pain were more in the placebo group as compared to the HES and lignocaine, which was significant, statistically significant. So you can see 66.37% of patients were having no pain in HES group, whereas it was 29.20 in lignocaine group and 11.5% in placebo group. It was significantly less, more in the HES group, no pain. Whereas coming to the severity scores, so HES and lignocaine was comparable in terms of severity, whereas HES and lignocaine both were superior to placebo in terms of severity. So here you can see in HES, 81% of the patient were having mild pain, 13% has moderate pain, and 5.26% has severe pain. In lignocaine group, 75% had mild pain, 18% has moderate, and 6.25% had severe pain. Whereas in this placebo group, it was 48% severe, 44% moderate, and 8% of mild pain. The mean interquartile pain scores were 0, 1, and 2 respectively in HES, lignocaine, and placebo groups. So coming to the discussion, these results validate our hypothesis that is pre-administration of 6% hydroxycycline significantly reduces the pain of propofol injection as compared to lignocaine and placebo. Mishra et al. Had done a similar study, and the results were consistent with the present study. In the study done by Mishra et al., they found the incidence of moderate to severe pain was higher in normal saline group as compared to HES. This can be explained by the fact that in their study, they had compared HES with lignocaine and lignocaine alone. So, and we had used 3 different groups, that is HES, lignocaine, and placebo. So this can explain the difference between the 2 studies. Coming to the mechanism of HES, it likely reduces the pain by protecting the vascular endothelial activation and prevention of propofol-induced activation of nociceptive pathway. This has been proved in multiple studies in vitro. Coming to the limitation, it was a single-center study with a relatively small sample size. Larger RCTs are required to validate these observations. And the optimum volume, that is 100 ml of HES, needs to be further investigated. So coming to the conclusion, the proportion of patients experiencing pain on propofol injection was found to be significantly less with pre-administration of 100 ml of 6% HES as compared to lignocaine. So pre-treatment with 6% HES is a promising strategy for reducing the pain of propofol outcome in injection. Thank you. These are my references. Thank you.
Thank you, sir. Over to Dr. Anju ma'am and Dr. Indrani ma'am for discussion.
Thank you, Dr. Saurabh. My main question is when lignocaine has been, in the current literature has been said to be the gold standard for preventing pain of propofol injection. What is the need for adding a placebo group to the study?
Ma'am, after using pain, the incidence of pain of propofol injection with the use of lignocaine still is about 20 to 60%, which is a significant pain. So, and I got to the literature and see that this can be used. And of course, the membrane, HES acts by reducing the activation of endothelial membrane, which is the mechanism of pain of propofol injection. That lead to me in deciding this study to be done.
No. My question here is, I understand that HES may have theoretically some benefits over lignocaine.
Yes,
but having said that, placebo arm patients are actually ethically not receiving anything for propofol pain. Correct. So what is the need for adding a placebo arm once we could have easily compared with the current gold standard or the current standard of care, that is lignocaine, and compare it with
actually,
this is a methodological issue that I'm pointing you out up there of adding a placebo arm to the study.
Yes, ma'am. Ma'am, I added placebo because I wanted to basically I want to know the effect of HES as compared to the nothing.
Anyway, and what is the incidence of anaphylaxis, considering that, hetastarches are known to exhibit anaphylaxis in a larger proportion of patients as compared to lignocaine that you were using in the other arm.
Yes, ma'am. But
so did you find them?
There were no reports in my patients. There were no incidences of any anaphylactic reaction or allergic reactions were there.
Okay. Have you looked at the literature that talks about different volumes of HES to be used for propofol pain injection? So because we just use one particular volume. I know you did mention that as one of your limitations of the study, but
The literature says 100
what is the optimum volume? There have been enough data that has looked at this particular, HES as
literature says that approximately 100 to 200 ml of volume is required because the volume needs to be in the vessels to act for the basically membrane stabilization. So we chose the lower end of the volume, that is 100 ml. And also the previous studies has also used 100 ml of volume of HAS.
Thank you so much. Dr. Indrani, I believe, is a little busy, so I think we can go to the next speaker.
Okay, ma'am.
Is she there or? Thank you, Beta.
I would like to invite Dr. Vasudha Govil, ma'am. She is Associate Professor in Department of Anesthesiology and Critical Care, PGIMS, Rohtak. Her topic would be retrospective analysis of snake bite victims admitted in intensive care unit of tertiary care hospital in North India. Ma'am, please welcome.
Thank you so much. Is my screen visible?
Yes, ma'am.
Yes.
Thank you so much, Dr. Neha. Thank you for the introduction. So my topic of discussion is my research, which is a retrospective analysis of snakebite victims admitted in intensive care unit of a tertiary care hospital in Northern India. So as we all know, just a minute, ma'am. Sorry for the interruption. Yeah. So as we all know, the big four of the snakes include the cobras, the kraits, saw-scaled vipers, and the Russell's viper. In India alone, 2 to 3 lakh of the snakebite cases are reported annually, with 1,000 to 2,500 deaths. And as per the WHO, the snake envenoming in India is on the priority list of the neglected tropical diseases. The most common neurotoxic snakes encountered in northern India include the cobra and the kraits. The most common cause of mortality in the snakebite victims is respiratory paralysis, which is preventable if the victim reaches hospital in time without any delay. So early diagnosis of neuroparalysis and early administration of anti-snake venom prevents further complications by neutralizing the snake venom. So the aim of my study is to evaluate the major factors that influenced the morbidity and mortality of snakebite victims admitted in the intensive care unit of a tertiary care hospital in northern India. So we recorded the data retrospectively from the time of presentation in medicine emergency to discharge from the critical care unit during the year June 2023 to May 2024. The patients were admitted in ICU after initial management in the emergency unit, and the management was further done in the 30-bedded modular intensive care unit of our hospital, which is a tertiary care hospital. All the snakebite victims, which are 18 years and above, who presented in the medicine emergency with neurological signs and symptoms in the stated time duration, were screened by the researcher. The data of only those patients who were subsequently shifted in ICU after management in the medicine emergency was recorded and further analyzed, and all the incomplete case records were excluded from the study. So we recorded the following parameters. First was the demographic characteristics of the patients, which included the age and gender of the patient, their month of admission, the time of snake bite, the associated comorbidity, if any, presented by the patient, the snake bite characteristics, which included the visible bite mark, whether it is present or absent, the site of the bite mark, whether it is present on the extremity or central in location, the presenting signs and symptoms of the patient. Then regarding the hospital admission and course of stay, the time taken by the victim to arrive at the hospital from the time of bite, the duration of mechanical ventilation if required for the patient, time to complete resolution of symptoms, and mortality if any reported. Then regarding the ASV usage, the time to the first ASV from the time of bite and the total dose of the ASV received by the patient. So we observed that out of 140 patients who were registered at the institute with history of snake bite during the year June 2023 to May 2024, 42 patients were admitted in ICU after initial management in medicine emergency following the snake bite, And out of those 42 patients, 30 patients met the inclusion criteria with complete records and included for the final study. Most of the patients presented in the early morning hours between 12 a.m. to 6 a.m. 18 patients were male and 12 patients were females, with maximum patients in the age group ranging from 25 to 50 years. 80% of the patients presented in the monsoon months of July and August, which are the months of heavy rainfall and high humidity. The flooding of their dwelling places of the snakes causes them to move out and cause human victimization. 6 patients had history of associated comorbidities, mainly hypertension, diabetes, and ischemic heart disease. So as we can see, the 60% of the patients were male as compared to 40% females. And the time of snakebite, the maximum patients presented in the duration of 12 a.m. to 6 a.m., which were 87%. In the snakebite characteristics, bite mark was seen in 63% of the patients. They were more often seen on the extremities as compared to the central location. Ptosis was the most common sign which was present in all the snakebite patients. Now, these are the presenting signs and symptoms, which included ptosis, which was present in all the 30 patients, followed by dysphagia, present in 27 patients, followed by dyspnea in 26, followed by diplopia, dysphonia, and dysarthria. Then the time of reporting to the hospital by the victim after the snake bite, it varied from 2 hours to 19 hours by the patients. 24 patients had complaint of breathlessness, which progressed to paralysis of the respiratory muscles, and they were intubated and put on mechanical ventilation. 6 patients did not require any mechanical ventilation and managed by the oxygen therapy alone. The duration of mechanical ventilation varied from 23 hours to 9 days. Time duration for complete resolution of the symptoms took an average of 43 hours, and 3 patients could not make and expired after the prolonged treatment in critical care unit. So this was the time taken to arrive at the hospital. Most of the patients presented within 3 hours of the snake bite, which were 15, followed by 11 patients during 3 to 6 hours, and more than 6 hours, 4 patients. Then this was the duration of mechanical ventilation which was required. 6 patients did not require any mechanical ventilation, were managed on oxygen therapy. 1 patient required mechanical ventilation for less than 24 hours. Maximum patients required it for 24 to 36 hours, which was 17, followed by 3 patients each in 36 to 48 hours and more than 48 hours. Then time to complete resolution of symptoms, 3 patients expired, so no resolution of symptoms was there. Maximum patient is resolved within a time period of 24 to 36 hours, followed by 36 to 48 hours, 8 patients, and more than 2 days, 2 patients took the time. Then for the ASV usage, first dose of the ASV was administered in the emergency unit, slowly over a duration of 1 hour in all the patients. The mean ASV received by all the patients was for 35 vials. The time to first ASV administration, it varied from 2 hours to 20 hours. This 20 hours is because one patient which was received her first ASV, it was after 24 hours as she had another hospital admission prior to presenting to our institute, and where there was no ASV given. So less than 3 hours, maximum patients received ASV, 15, then followed by 3 to 6 hours, 11, and then more than 6 hours, 4 patients. So an association between the time to the first ASV administration from the time of snakebite and the time to complete resolution of symptoms was noted, and it was found to be highly significant with p-value of less than 0.05. Similarly, association between time to first ASV administration from the time of snakebite and duration of mechanical ventilation was also found to be highly significant with a p-value of less than 0.05. Neuroparalysis is the leading cause of increased morbidity and mortality in the neurotoxic snakebite patients in northern India. The victims presented with the classical triad of ptosis, the blurring of vision and body weakness, and this weakness was attributed to the snake venom toxin, which bind to the presynaptic and postsynaptic receptors, causing structural damage at the motor end plates, causing muscle weakness of the eyes, tongue, throat, and chest, leading to respiratory failure. Majority of the victims were young males in the age group of 25 to 50 years, which are the dominant working members of the family, working early in the farms or sleeping in the farmyards. Decreased visibility in the early morning increased the chances of midnight or early morning bite. And similar findings were seen in the studies which are conducted by Brinda G et al. And Anil et al. As far as ASV is concerned, in India, it is polyvalent ASV. It neutralizes the unbound snake venom. So most efficacious when administered within 1 to 4 hours of the snake bite. So early arrival at the hospital after snake bite and early administration of the ASV came out with the best outcome. Now, in case of respiratory failure, early intubation and mechanical ventilation was done to protect the airway and prevent aspiration in patients with bulbar paralysis. Lung mechanics are usually normal in snakebite patients, so patients recover faster from neuroparalysis with prompt administration of ASV. Early extubation decreased the chances of ventilator-associated pneumonia, and none of the patients in our setup developed VAP in the study. The mean time to complete resolution of the symptoms was 43 hours, and the mean ASV received was 35 vials in the study. The average dose was similar with other studies as well. As already discussed, all the patients except 3 recovered completely, and it could be attributed to the associated comorbidities which they had, ranging from IHD, uncontrolled hypertension, and uncontrolled diabetes mellitus. So there are strengths as well as limitations of the study. The strength lies in the fact that identification of the crucial months can be done, which is the monsoon season of July till September. Then hospital may be prepared during these months. The common signs and symptoms, identification of the neurotoxic bite, and the factors that may influence the outcome may be seen by the hospitals and managed accordingly. However, the limitations of the study are less number of patients were analyzed as compared to the Indian population as such, which might not reflect the exact statistics of the study. So we concluded that the early arrival at the hospital with early institution of treatment and ASV administration resulted in better outcome of the neurotoxic snake envenomation and early resolution of the neuroparalytic signs and symptoms in the snake bite patients. Thank you.
I think that is quite obvious, right?
Yeah.
The patient comes early, detected early, treated early, outcome will be better. So that is very obvious. But my question is, how did you differentiate between the species? Was the expected species written in your case because it's a retrospective analysis, or is it just based on symptoms?
It was just based on symptoms. The species could not be identified until unless the patient identifies that it was this type of snake. So it was just purely on the basis of the neuroparalytic symptoms that the species were identified.
Were there any patients with neuromuscular disorder pre-existing?
No, ma'am, not mentioned in the case reports as such that the patients had any neuromuscular disorder. If there would have been, it would have been mentioned that the patient had.
So, did you preemptively intubate the patients?
Yes, ma'am. We did that.
Why not non-invasive ventilation?
Because as per the previous literature, it was that the lung mechanics are not interfered in the snakebite patients.
So no reason.
Yes, for that reason, we intubated the patient because it was expected. When the patient started showing the symptoms of muscle weakness, the patients were intubated. And if we did early intubation, the patients were extubated early also.
No, okay. Because it's a retrospective, you had no choice to know whether there was non-invasive ventilation or whether it was intubation.
No, ma'am, we had the case records of intubation that the patient was intubated and not put on NIV.
Okay. How many of them needed a redosing after extubation?
Redosing as in, ma'am, ASV. Many patients, ma'am, because the symptom which did not subside even after the extubation was ptosis. Ptosis was
you should have your statistics on that also, right? How many of them needed redosing after extubation? You have given your initial dose of 10 ampules.
Yes, ma'am.
Right? 10 vials, sorry, 10 vials.
Yes, ma'am.
And then based on the neuro weakness or based on what the symptom, the thing was given, further dosing was done, right? And my question is, after extubation,
yes, ma'am,
how many of them needed redosing?
Yes, ma'am. Exact stats we don't have, but what the protocols that we followed included that if the patient had persistent ptosis, the ASV was given. And ptosis was not the criteria of not extubating the patient.
What about other secondary complications? Did you notice? You said there was no VAP.
No, ma'am. There was no VAP because the maximum patients were extubated within a period of 36 hours.
But what about kidney AKI or,
Ma'am, only as far as these 30 patients are concerned, we had just one patient who landed in this AKI and she
liver.
expired eventually. So we just encountered one patient who went on to dialysis and AKI. She had an intubation period of approximately 9 days, 9 to 10 days. And she could not make it up.
So did you correlate it with the time of arrival of the patient? What was the delay after the snake bite and whether that correlated with the outcome?
Yes, ma'am. She was the only patient who arrived after 20 hours of the snake bite because they went to a peripheral setup first and then they arrived at our hospital and she could not receive that ASV at the peripheral care unit. So she received the first ASV dose after 20 hours. And when she came, she was immediately intubated and was shifted to ICU. So she was the only patient who was intubated for 9 days and finally expired and landed into all these complications.
So the very nice, compilation. You looked at a retrospective data. Of course, I understand the concerns of having just 30 patients on your data. Would have been better, just a comment, that had your data basically looked at outcomes and compared them to some kind of a benchmarks as to whether interventions provided into your setup on a retrospective data, whatever your observations were they at par with the standard SOPs across and any benchmark? So that would help you to have some kind of quality improvement. One and two, you could have in future some kind of multi-center trials because Assam and Northeast areas are areas which have maximum number of snake bites. So that kind of data compilation can really help formulate future guidelines and
We are
protocols.
going on with a multi-center trial right now for these snake bite patients.
Good.
So it will be a prospective study.
Yes, ma'am. It is a prospective study which is going on, and it would compile the data of 3 years, and in the multi-center.
So do you have institutes from areas where snake bites are more common?
Then we have one institute from Assam.
Assam has a very big,
Because
volume out there.
because
So had you incorporated lot many, you would have got a lot good number coming. So thank you so much. Good luck with your work.
Thank you.
Thank you, ma'am. Moving on to the next speaker. Dr. Raghav Gupta. He is Assistant Professor, Department of Onco-Anesthesia and Palliative Medicine, National Cancer Institute, AIIMS, New Delhi. His topic would be perioperative anesthetic management in cytoreductive surgery with hyperthermic intraperitoneal chemotherapy, a retrospective analysis in single tertiary center. So please proceed.
Very good evening. Are my slides visible?
Yes.
Very good evening to all the faculty members and respected colleagues. I would like to thank my mentors for helping me out in the conducting of my research project, which is titled Perioperative Anesthetic Management in Cytoreductive Surgery with Hyperthermic Intraperitoneal Chemotherapy, a retrospective analysis in a single tertiary care cancer center. The scope of my presentation would include the introduction and the rationale, followed by methodology and the results, and ending in discussion and conclusion. So CRS and HIPEC, it's a multimodal treatment option for select group of patients with peritoneal surface malignancies. And the HIPEC phase involves infusion of the chemotherapeutic agents heated at 42 to 43 degrees Celsius into the peritoneal cavity after the cytoreductive phase is over. So there are a lot of marked pathophysiological changes which have a lot of anesthetic implications for perioperative care. And in such kind of surgeries, intraoperative fluid losses may be as high as 8 to 12 mils per kg body weight. So what are the causes of significant fluid shift in such kind of surgeries? It is suboptimal nutritional status, a lot of intraoperative blood and fluid loss, intraoperative vasodilatation due to systemic inflammatory response to the surgery, and the pharmacological vasodilatation caused by the neuraxial block and the systemic anesthetic drug. So what was the rationale behind conducting the study? The higher peritoneal carcinomatosis index, longer duration of surgeries, high delta temperatures, increased blood loss, high intraoperative fluid requirement, low mean arterial pressure, and high blood products requirement have been seen in studies to be associated with more than 24 hours of postoperative ventilation, as well as ICU stay more than 4-5 days. But still, there is a limited literature on the anesthetic technique which we should be using and the outcomes following this surgery from the developing world. In this study, we retrospectively analyzed the effect of perioperative anesthetic variables during the CRS HIPEC surgeries on the overall outcomes. So the study was conducted at Tertiary Care Cancer Institute at AIIMS, New Delhi. The Institutional Ethical Committee approval was obtained following by CTRA registration. The study design followed by retrospective analysis with data collected from January 2015 till July 2020. And the patients included were age group more than 18 years and who underwent CRS HIPEC surgeries for peritoneal surface malignancy. We excluded the patients who underwent stage procedures, those requiring emergency re-exploration, and those with incomplete data. So the data required were collected from the patient's file, the nursing charts, the IC records, and our electronic database. And the data was subsequently entered into the standardized performer and analyzed using STATA version 14. Pearson's and Spearman's correlation coefficients were used to determine the strength of correlation and association. So what were the different data collected? Demographic parameters such as age, gender, body mass index, American Society of Anesthesiology grading, comorbidities, and the preoperative treatment history. The details of the anesthetic techniques used, the vital parameters, the total amount of fluid in the blood given in 3 different phases, that is the CRS, HIPEC, and the post-HIPEC phase, the urine output during the 3 phases, the blood gas analysis, the inotropic requirement, and the peritoneal carcinosis index score. We also observed the post-operative urine output, timing of the extubation, the length of ICU stay, the kidney function test, and acute kidney injury classification. And the surgical complications were categorized using modified Clavin-Dindo classification. So, based upon these parameters, the perioperative fluid therapy, duration of surgery, and PCI were correlated with the perioperative lactate levels, length of ICU stay, Eching classification, and modified Clavin-Dindo classification, and the effect of delta temperature, that is the maximum temperature obtained during the HIPEC phase and the minimum temperature during the CRS phase, on the amount of blood loss intraoperatively, the use of inotropes intraoperatively, and the coagulation parameters on the postoperative phase. So we reviewed the records of 205 patients, out of which excluded 25 patients because of incomplete data. In total, 180 patients were reviewed and analyzed. Mean age was 48 years, with 85% of them belonging to the female gender. Most tumors were ovarian in origin, that is 63%. The mean PCI score in our study was 15.76 plus minus 5.15. The mean intraoperative fluid given was 4295 ml. The mean duration of surgery was 5.35 to 7.35 hours. Blood loss ranged from approximately 200 ml to 1 liter. And the length of ICU stay was 1.4 plus minus 0.58 days. So what was the correlation found between the total fluid and the intraoperative lactate levels? So what we saw was that there was a negative correlation during the CRS phase as well as the HIPEC phase, with the p-value being statistically significant of less than 0.05. The second correlation we found was the total fluid and the post-operative lactate levels. In that, we found that lactate levels at 6 hours of post-surgery had a negative correlation with a statistical significance, but at 12 hours and 24 hours post-surgery, there was no statistical significance found. So this was the box plot describing the arterial lactate at 5 different time points, the maximum lactate levels during the CRS in the HIPEC phase, and post-operatively at 6 hours, 12 hours, and 24 hours. Then we studied the correlation between the total fluid and the length of the ICU stay, and we saw that there was a positive correlation with statistical significance between the total fluid given and the length of the ICU stay for the patient. Then we saw the association between total fluid and the acute kidney injury classification, and there was no association found between the total fluid given and the acute kidney injury classification immediately after surgery as well as 24 hours post-surgery. There was no association found between total fluid given and the 30-day mortality rate. Coming to the correlation between the blood loss and the post-operative outcomes, we saw that there was an association present between the blood loss and the day of extubation statistical significance, as well as with the length, positive correlation with the length of ICU stay. But there was no association found in the Clavin-Dindo classification for the surgical outcomes. Coming to the correlation between the duration of surgery and the length of ICU stay, there was a positive correlation with a statistical significance that more the duration of surgery, it led to prolonged length of ICU stay. Correlation between the PCI and the length of ICU, very important parameter in CRS HIPEC surgery, is the peritoneal carcinosis index, and we found that there was a correlation between the higher PCI index and the length of ICU stay with a statistical significance. Then correlation between the delta temperature and the different perioperative parameters. So what we saw was that the different perioperative parameters, including the coagulation profile, there was a statistical significance whenever the delta temperature range was more, there was an increased requirement of inotropic requirement during the CRS phase. During the hypec phase, there was more blood loss as well as there was coagulopathy in the postoperative period. So coming to the discussion, so there are various strategies for fluid management which have been described in literature ranging from liberal, restrictive, and goal directive. Lactate being one of the surrogate marker for tissue perfusion, and increased levels of lactate denotes tissue hypoperfusion, anaerobic metabolism, and increased glucose metabolism. So in our study, we found a negative correlation between the total amount of fluid infused and the intra-op and post-op lactate levels, which was statistically significant at different phases. This could be due to the maintenance of adequate tissue perfusion by liberal amount of fluid given. We found a positive correlation between the amount of fluid given and the length of ICU stay, which was statistically significant, and the same has been studied by Dr. Kalpana et al., in which they observed longer ICU stay for patients given more fluid. There was no association found between the total fluid given and the 30-day mortality and acute kidney injury in our study. And there was a landmark trial by Miles et al. By the name of Relief trial, in which they observed that the probability of acute kidney injury was more in the group given the restricted fluid regimen. And another study by Colantonio et al., they advocate that goal-directed fluid therapy in these kind of cases and say it decreases the morbidity and hospital length of stay and mortality. In our study, a significant correlation was observed between the amount of fluid, blood loss, and the post-operative requirement of ventilation and duration of ICU stay. This is in similarity to the recent review on intensive care outcomes after CRS hypec by Dr. Kapoor et al., in which they concluded that the amount of blood loss and blood product requirement affected the length of ICU stay. So what are the limitations of a study? It's a retrospective study. It's a difficult to draw cause-effect relationship between the amount of intraoperative fluid given and the post-operative outcomes when it comes to terms of length of ICU stay and the mortality. It was a study conducted at a single tertiary care cancer center, and the results may vary in different institutions depending upon the expertise and facilities available. These data spanned over a period of 5 years, during which there have been changes in the anesthetic as well as the surgical technique, and the anesthesia management of the patient varied and did not follow strict protocol. So these were the limitations, and based upon these limitations, it's our envisage, and we have started working on it to formulate a prospective trial at a multi-centric study to come on and with more data pertaining to these factors. So in my conclusion, I would want to mention that peritoneal carcinomatosis index and length of surgery were the major predictors of post-operative morbidity in terms of duration of ICU stay, the need of post-operative ventilation, the poor modified Clavin-Dindos score, and 30-day mortality. Second, the total amount of fluid given correlated well with the length of ICU stay. Third, the increased delta temperature was associated with more blood loss, increased intraoperative inotropic requirement, and deranged coagulation profile in the postoperative period. And fourth, excessive blood loss was positively correlated with the need for postoperative ventilation and length of ICU stay. Thank you.
Thank you, sir. I request Dr. Anju ma'am and Dr. Indrani ma'am to please proceed with the discussion.
Thank you, Dr. Raghav.
Thank you, ma'am.
Indeed, a good retrospective analysis, and you did say that it spanned for 5 years. So like over the period of 5 years, did the protocols, the anesthetic management, the goals, the surgeons, the anesthesiologists change? Because that would all kind of, change our outcomes. And
So, ma'am, that happened, ma'am. Surgery, CRS hypec surgery started around in that period, 2015 at AIIMS, ma'am. And during this was my DM dissertation, ma'am. I was a senior resident at that point of time. And myself, I saw that there were a lot of changes in our practice as an anesthetist, as well as the surgeon's expertise, because initially they were taking more time. There used to be more blood loss in the surgeries. But over a period of time, the duration of surgery also decreased and the surgical techniques improved. So I have personally seen a lot of changes at both the ends, ma'am, anesthetic as well as the surgical end. And that has definitely, I'm sure, led to a lot of changes in our study results.
So was it a goal-directed or restrictive or a liberal fluid management?
So, ma'am, initially what we followed at our institute was more of a liberal one. But gradually, over a period of time, it has now shifted to restrictive and goal-directed fluid therapy.
In your retrospective study.
Ma'am, in my retrospective study, initially, ma'am, as I said, because that data we didn't have in a categorization form that initially whether it was liberal or not. But based upon the amount of fluid given, we can mention that initial phases of those 5 year span, it was more of liberal, and later on, it gradually changed to goal-directed fluid therapy.
But because you said it is the anesthesia, because the anesthesia was not looked into. So that was your scope of your study, isn't it?
Yes, ma'am,
Perioperative
definitely.
anesthetic management, right?
Yes, ma'am.
So did you consider the type of anesthesia which was given? GA with epidural or spinal? Because most of
Ma'am,
your cases are ovarian tumors.
yes, ma'am. So by default, in all the cases, we are giving general anesthesia along with epidural. So in my study, I took only those cases in which there was general anesthesia along with epidural anesthesia. In few of the cases, yes, we do practice general anesthesia with intrathecal morphine also, ma'am. But those cases have been excluded in the study, ma'am.
So do you think that can affect your fluid management?
Definitely, ma'am, because as I mentioned, that epidural block along with local anesthetic infusions may lead to systemic vasodilation and decrease in the blood pressure in perioperative hemodynamic changes.
Were static parameters used for fluid therapy or dynamic parameters? Did you have cardiac output? Did you
Yes,
have...
ma'am. Over the last like 2019 and 2020 period, that time we have started using dynamic parameters, but the initial few years it was static parameters based upon the heart rate, the urine output, and the blood pressure.
So
the outputs
sub-analysis could answer this question that madam is asking you, year-wise data coming
Yes,
in.
ma'am,
And
that I should have done, ma'am.
Trend can let us know what it is.
Yes, ma'am.
So, what about the patients where they're anemic, where they're frail, where they, even that also affects outcome and length of stay. Did you consider those factors, prehabilitation?
Ma'am, unfortunately, not in this retrospective analysis. I do not have that categorization of the hemoglobin levels and the patient frailty score.
Because that is easily available in your, so probably that
Absolutely.
also should have
Absolutely,
been
ma'am.
included
Point
in
taken, ma'am. For the future prospective trials which we are planning, ma'am, I'll definitely include these points.
All right. And delta temperature. So, how did you manage the temperature? Because did all of them have a steady state of temperature, or was it kind of a
Ma'am,
variable
there
factor?
was variable factors, ma'am, fluctuations. As I mentioned, ma'am, since it's a retrospective analysis, so it wasn't in my control. But initial practices used to be that we always used to, along with cold fluid, we also used to have ice packs and all during the
Right.
initial phase, ma'am. But later on, when we saw that there was harm because of the cold packs in the axilla and all, so now our strategy has been to switch off the bear hugger and to use cold IV fluids during the hypic phase. And during the CRS phase, just like any other case, we try to maintain the patient in normothermia with using the warm IV fluid as well as the blankets, ma'am.
Did you see any changes in coagulation parameters? Sorry, ma'am.
Yes, ma'am. There were changes. There was coagulopathy in the postoperative period in the cases in which the fluctuation was more, ma'am. So it's a retrospective study. So we saw that the cases in which there was more of fluctuation, like 2 to 2.5 degrees Celsius between the CRS and the hypic phase, there was more coagulopathy in the postoperative period. The INR used to get deranged.
So that was uniform in all the patients.
Yes, ma'am.
And because 80% of your cases are women, will you extend the same result to men? Non-gynecological surgeries?
Ma'am, difficult to say based upon that only. I guess we should study more because there can be changes in the hemodynamic. The baseline blood pressure can be different in such kind of patients. As you mentioned, ma'am, the frailty may be there. And many a times, women patients also have, ma'am, a lot of ascites and sea ovary cases in such kind of cases. So the fluid drainage, that itself can lead to hemodynamic fluctuations when the surgeons open up initially. So difficult to translate the same data into the
non-gynecological surgeries, gynecological versus non-gynecological surgeries.
Yes, ma'am.
Also, your age difference was also quite vast, right? Ranging from 20 to old patient, right? So, so that also can make a difference in the fluid management as well as the outcomes.
Definitely, ma'am. That age, frailty, gender, all these
Yes,
can be the
the
confounding
presence of
factors.
anemia. Yes, right.
Yes, ma'am.
Good, very good presentation. Thank you.
Thanks, ma'am. Thanks, ma'am. Thanks so much.
Thank you, ma'am. Now I would request our judges, Dr. Anju ma'am and Dr. Indrani ma'am, to please give their valuable remarks regarding today's session.
I think all of them, all the studies were very high quality, and the presentation was also good. I mean, there are a lot of take homes which I found in many of the studies, and also it incited, incited that we can probably work more on the same study. Many of the studies had scope for working more on it, to make it more robust. So, all in all, I think our future is very good. Our youngsters are doing very well, and we are leaving the mantle in very good hands.
Well said, ma'am.
Thank
I
you so
just
much.
wanted to add that, I would like that young population, our young Turks, I would say, to take forward patient-reported outcomes. That is something that we should now be more focusing on. And so that we can really make a difference to the clinical long-term outcomes as well as short-term. But long-term outcomes and especially are pretty important in this particular perspective. But yes, very well reassuring to see such good high-quality studies coming in and good way of data analysis, which of course, as you all will grow further, I'm sure you'll do much more better and be there on the international arena as well to showcase. We have to remember that we do much more than what we actually document and record and analyze and take it further. So that's something that if we all keep doing, it will be a great change and a great benchmark for our country. Thank you so much.
Thank you, ma'am. Thank you so much for taking out your valuable time for this wonderful session, ma'am. Now I request Dr. Tanveer sir to please give vote of thanks.
Well, it's a great opportunity to propose a vote of thanks for this RSA Youth Conclave second webinar. Thanks to our patron, RSACP, Dr. Tej K. Kaul, sir. He's a teacher of teachers. And I say so because Dr. Anju ma'am is my teacher and this sir has been her teacher. So, and a special thanks to Dr. Naveen sir, President RSACP, and Dr. Vishal sir, Secretary RSACP, who always lend support to the youth anesthetists. They gave us this platform. The entire idea was supported by them, and we started with all this. Special thanks to our judges who had I hope they had a tough time judging all these 7 participants. Special thanks to Dr. Indrani Hemat Kumar ma'am, past president RSACP, and Dr. Anju Garewal ma'am, my teacher and my mentor, and president-elect RSACP. They accepted our request to judge these participants and spared more than 2.5 hours of their precious time. Thank you so much, ma'am. Thanks to my co-coordinators, Dr. Neha Mishra, Dr. Neha Sinha, and Dr. Nitin Chaudhary. Special and above all, thanks to all the participants. And I hope all judges will agree with me. All were marvelous. All did an exceptional job in presenting all this, all their presentations. And thanks to all the people who joined, the delegates who have surely gained from this webinar of ours. And the winner will be announced in the next webinar and after both the judges combine their results. And thanks to one and all. Thank you. Long live RSACP.
Long live RSACP.
Thank you so much.
Thank you, sir.